Greetings, this is Bill Morgan, president of Parker University, and this is Point of View. With me today, I have Dr. Katie Pohlman, who's a chiropractor and a PhD candidate, and Dr. Rob Rosenbaum, medical doctor, neurosurgeon. And our paths have crossed before. As all three of us worked at Walter Reed National Military Medical Center on a very large chiropractic study, and we're here to talk about this today. And Katie, you were one of the authors in that study. And Dr. Rosenbaum was the site investigator, and I was one of the treating doctors. And we both all worked together trying to get it through the IRB and to get the site set up. But we're here to talk about that study, which was recently published in JAMA. So, Katie, can you tell us a little bit about the study?
Yeah, so I was the lead project manager, and so I was my job was to take the grant application, the successfully funded grant application that in and of itself was a year or two of work. So when it was funded, it was handed into my lap to work with all of the site principal investigators and treating docs to say, how can we actually make this happen? And there was 3 sites, and you guys were at the Walter Reed in Washington, D.C. There was one in San Diego and Pensacola, and each of them were to recruit 250 active duty military personnel with low back pain, and that could be acute, chronic, or subacute. And that was successfully done, and it took us about 3 years to do that.
A lot of work. I know Dr. Rosenbaum, you put a lot of work in, thankless hours helping get this study move forward. I'd like to thank you for it, first off. And how was the getting it through the review process, the IRB?
Absolutely. Well, thanks for having me, Bill. Getting it through the IRB was difficult. That, as Katie remembers, it was the hardest part of the entire study. It's interesting, when you said it lasted 3 years, to me, that was a 6 or 7 year study. But I think the majority of the time that I was engaged on that study was the IRB process, and getting it kicked back and fighting with the IRB and having to meet the exclusions and the requirement criteria. And ultimately, as you mentioned, having it sent to another site, somewhat disappointing, because we had worked very hard at Bethesda, then the Naval Hospital, to make that the primary site. And it's exceedingly frustrating when you have those types of hurdles pushing against what you are trying to accomplish. They're important to recognize those hurdles are there for the patient's safety and to ensure that all the requirements are met. But that really was the hardest part. I think that was the hardest part of this study.
I remember it was like pulling your own teeth out to get it done. And people don't understand how hard it is to do good, solid research like this. To have a randomized control study, you have, especially if you're working with the government, and also the population is, they're not. What's the word they use?
Vulnerable.
A vulnerable population. So you have greater depths that we have to go to as we're putting this, because you can't have their boss order them to do a study. They have to be volunteers. We have to provide care for them and options.
Yeah, so there was 5 IRBs we had to go through, and we went through them each one at a time. But if one made a change, then we had to go back to the other one and keep going through the process before we could get it started. And so that was a huge hurdle. And one of the one challenge that we thankfully overcame was one of the sites told us that because chiropractic care was offered at their base, was that if we did the study and we told the one group that they couldn't have chiropractic care, we were taking a right away from them. But we were able to successfully overcome that because it was at a base that they had one chiropractor for the 30,000 military active duty personnel. And so we said, is that really access to care? And they allowed the study to continue.
That's interesting. So they didn't want to do the study because they didn't want to have the control group be denied chiropractic care. That's how much they valued it. Yep. So with it, what was the outcome of the study? And where was it published?
It was published in JAMA, and it was in JAMA's first open access journal. It was their inaugural edition of that journal, and so that was a really big deal for the chiropractic profession. And the results were a clear benefit by adding chiropractic care to usual medical care, and the study was powered so that each site could stand on its own. So that made it even stronger. So each site, with the 250 at their site, had a distinct difference or improvement. And then together it showed it was the first positive study that was powered to be able to show a difference like that.
So it wasn't just because I was treating at one site and I carried everybody.
That may have been it, sir.
Okay.
Boss.
So so how do you see this as a what's the value in this, Dr. Rosenbaum, this study? What do you think it
This
shows
really
us?
goes to support the clinical practice guidelines that we've been using. Bill, you and I have been using these for over 15 years now. I started using a clinical practice guideline in 2002, and it clearly delineated chiropractic as a form of effective early care. In 2007, there were formal guidelines released. Chow et al. Supported the use of chiropractic care. It was reiterated in 2017, and I think that the guidelines exist, but the raw data now is easily in support of what we're doing. And we need to open the doors and allow the chiropractic community access to the patients and allow them to decrease the burden on allopathic medicine and support the directed care for these patients, as has been illustrated by this study.
And you and I have long been champions of collaboration and integration. Those may be two different things. It's important to realize that the medical group, the control, well, it's not a control, but the medical group, they were allowed to do whatever they wanted care-wise, except for the chiropractic. They could send the patients to physical therapy. They could send their patients to physical therapists who do manipulation. So even comparing that to the chiropractors, who are, again, were allowed to do what was ever in the best interest of the patients, we were able to do that. The limitations were, I think, 12 visits was the most we could see, but the average was 4 visits, and we still had that significant of improvement.
That's quite powerful.
Can I ask you, as a treating doc, the study was designed as pragmatic, so you could do, as the doctor, you would treat the patient as you would. The 4 patient visits that was on average, was that because of how you wanted to treat them, or is that because of your schedule?
Here's the deal: is when you're at a military hospital, you're buried. There's, we had 120,000 beneficiaries in our catchment area. Two full-time chiropractors. My wife Claire would come in periodically as a volunteer. We were just buried. Plus, they're working. The military, and to get to Walter Reed was no easy task. If you're coming from the Pentagon, by the time you do the trains and stuff, it might be an hour and a half to get there. So there was a lot of factors to it. It's accessibility by us, and they also had lives to live.
So likely not as pragmatic as you would like, but still positive outcomes.
Yes. It'd be interesting to see now ours was different because we're a tertiary care hospital. This is where people come from around the world for care, for neurosurgical care, for whatever. And you might have someplace like Camp Pendleton that has 45,000 Marines with with relatively easy access, drive over and get it done. And they're young, healthy people. So that's the value of these different sites is I always say the Pentagon's the elephant's graveyard. As they get older, they all end up there, and that's where they die. So I think we might have had a little bit older side of the population.
You did. Tell me about, this was done in a military setting. How do you think it could relate to a general practicing chiropractor or primary care doc?
Well, I'll tell you, I think that again, and I don't want to sound like a broken record, but the value here is access to care. Back pain, and we're talking really about back pain in these patients, but access to care for patients has decreased over the last decade to 15 years. The ability to now increase our patients' access to rapid and effective care it's immeasurable when you are somebody who is, again, trying to get to work. I think in the civilian community, it's less about measuring the impact on the primary care doctor or the chiropractor. It's more about the impact on the civilian who needs care. And if we look at it from the patient's perspective, what you see is somebody who now can legitimately and within the rights of medical data say, I'd like to see this person. And if that's a chiropractor, great. If it's an allopath, that's fine too. But in all reality, these patients now have a floodgate that is open because society has been illustrated that these are acceptable ways to get care. This is something Bill and I have known for a very long time. I have hundreds, if not thousands, of patients who have achieved excellent relief at his hands. The fact that we had to go down the road of this study just speaks to allopathic medicine's resistance to accept new, and I don't want to use the word alternative, but complementary versions of care. So for patients, it means that they can get out, they can go to a care provider, and many people can see you within a day or two of your calling if you're close enough or if their schedule allows. So I think the real impact comes from the ability to return people back to work, get them back up and running, doing what they like to do in life, and getting past being sick or being ill.
And talk about how we can generalize this to the population. One thing about military folks is we've eliminated a lot of the comorbid conditions by the time they're in the military. If you've got diabetes or chronic disease, you're not even allowed in the military. So we're able to have a pretty pure set of people who are healthy. This is a musculoskeletal injury with not a whole lot of comorbid, chatter or interference in there. So it was nice and clean that way as well. And of course, as you can speak to, our compliance rate was through the roof. What was it again? It was 90%.
90% at primary outcome. So at 6 weeks, we had a 90% compliance, and especially with the transient lifestyle of an active duty personnel, that was unheard of. That made the study really strong. And the diversity that we did have, it was a much younger population than has been published in the low back pain literature before in the past, as well as the diversity in the race and ethnicity hasn't been published. And so we were able to show benefits in both of those populations.
And as we go, if somebody needs neurosurgery, we know there's a need for neurosurgery and there's a need for conservative care. It's the in-between stuff, from epidural injections to opiates to even NSAIDs. And it's interesting that the JAMA study that it was just published comes right on the heels of another set of studies in the Lancet, which shows that you shouldn't start with drugs, even NSAIDs. Yep. And NSAIDs kill thousands of people a year. Opiates, certainly not. Epidurals, we should not be doing MRIs early on. We should start with things like cognitive care, chiropractic, exercise, and certainly if they came in with a conus medullaris syndrome, we better give them a neurosurgery right away. That's the most conservative thing we could possibly do. But those are, when they need neurosurgical intervention, it should be pretty black and white.
Absolutely. There's no reason to dance around that.
Yeah.
When the patients come in, you have to have the proper diagnosis. So, but as you mentioned, the MRIs are overdone today. I can't tell you the number of times I get called about an MRI on a patient with, quote, back pain for 3 days, 2 days, 6 days. It just doesn't make any sense. And if you use the algorithm that you and I've used for 15 plus years, it's near the end. It's inappropriate to do early imaging if you don't have a red flag. Now, you got to caveat that and say diagnostics prevails. You look for your red flags. If you have a reason to do the imaging study, that's completely appropriate. But back pain is not the reason to do the imaging study. True. And then you do the standard treatment. And in that respect, some of the algorithm that we used needs to be inverted a little bit. And the one I promulgated in Japan was heavy on NSAIDs. In our population, the young active duty male, it is something that you gave people, vitamin M, as everybody called it. So the cognitive therapy, right? the cognitive therapy, I think, is a huge piece of it. Behavioral modification is something that, all of us are violating the basic tenet right now. We're sitting. We shouldn't be sitting at all. But if you can get the patients away from those things early on, and this is something that chiropractic care focuses on, and this is one of the reasons that so many of my patients ended up in your clinic when they didn't have surgical disease, because I could depend on you taking the time to say, listen, here are the behavior modifications you need to make. My allopathic peers did it a different way. We had something called back school, and they'd send them to that. But the patients all went to that and said, well, they sent me to that silly 1 hour class that told me how to stand up and how to lift stuff. They weren't taking it seriously. But it's it's there for a reason, and it is effective.
So it's odd that we've all come together again, and it's like we were working together in Washington D.C. and now, and in this study, and now we've come to Parker University, where you're heading up research, and you're on the board of trustees, and I'm the president. It's just great that it's odd how this all came together full circle after, like you said, 15 years of interaction here. What do you think next steps are for research like this? What should be done next?
I think we need to end up in the world of wellness. I think the right next step, there's fertile ground here in terms of research, and we could go in almost any direction. But the right next step is wellness and health optimization. And if you truly want to illustrate, again, not a chiropractor, so maybe I'm off base, but if you truly want to illustrate the value of chiropractic care, comparing wellness and optimal performance in a relatively healthy population is, I think, a good next step. Now, that's a harder study to do because we are ill providers. As a rule, the chiropractic community lives in our sphere now, and having positioned itself to receive insurance payments has also put itself in the sphere of illness care. But in reality, I think that there is a much bigger window of opportunity to return people to a higher level of wellness.
Bingo. And you're exactly right, because people don't argue anymore about chiropractors taking care of musculoskeletal conditions. That's not even an issue at this point. It's when you delve into performance, wellness. Are you healthier by seeing a chiropractor? Does the chiropractor help you if you're in a smoking cessation program or want to having greater longevity? Those are claims that's tough to make because we don't have the research to substantiate that. So that looks to me, is that something we can solve with a randomized control study? Is that going to be big data sets? How would we possibly move to that step, Katie?
Well, maintenance of care right now is actually coming out of Sweden. And so 5 years ago, wellness care or maintenance care.
Has that study been published yet so we can talk about it?
Parts of it
Okay.
have been. And so the 5 years ago, nobody could even back that up with data, but we now can say there's some benefits to maintenance care, chiropractic care through using maintenance care. And so we are opening those doors. And
there's some exciting studies that are going to be published in the very near future.
Yep.
I think that it's going to shed light on that. Next step, if you're in the military, if you're a hierarchy of military, how would you interpret this study, and what would you do about it?
Look, the first thing I would do, Bill, is enhance or increase access to chiropractic care. One of the complaints that my patients had is lack of access. I had access because I could call you and say, hey, I've got a patient here I need to have seen. But technically, you were only allowed to see members of Congress or active duty people. Dependents, retirees, not eligible. And if we believe that this is effective, and if it's effective, then it's cost effective. If we believe that this is effective, then we open the gates to all of our beneficiaries, not just the active duty personnel. That means putting more chiropractors on base, or at the minimum, partnering with community chiropractors and increasing access in that respect. There's an entirely separate discussion about chiropractic in uniform. And I've heard both sides of that discussion, and frankly, not part of what I would get involved in because I don't know the pros or cons, and there's always unintended consequences. But I can tell you that we would have benefited from having a chiropractic provider in Kandahar. I would love to have had somebody there to help me because we had patients with back pain. We had patients with other musculoskeletal problems that would have benefited from that level of care. We couldn't do it.
And again, in Kandahar, of course, in Afghanistan. So as the military is kind of drawn down to a tighter, smaller services, you have less and less people who are responsible to win the wars. So if you lose 5% of them in musculoskeletal, temporary musculoskeletal injuries, that could determine the outcome of a conflict 5% loss of personnel. So, but if you were able to put them back in the fight by having a chiropractor maybe not forward deployed, maybe at a battalion or regimental level, you could put more people in there. You're going to increase the effectiveness of that fighting unit.
Oh, I'm certain.
Arguably,
I'm certain there are people like you who'd love to be forward deployed and do that.
Yeah.
And I think that would be fantastic. And I do believe that there's the ability to do that. We've illustrated that you can return people to the fight with simple things like battlefield acupuncture. You can reduce the distraction of pain and return someone to functioning. And if you can do it by a simple set of manipulations, why not keep your tip of the spear as thick as possible? You really want that access to the penetration to succeed in that fight, because the faster it's over, the less bloodshed there is.
Amen. Well, thank you both for being here. Now, you've gotten out of the military, you've retired, and you're in kind of a subspecialty of neurosurgery.
That's correct.
Taking care of Ehlers-Danlos patients?
That's correct. I joined Metropolitan Neurosurgery Group in Silver Spring, Maryland, and Fraser Henderson, and we care for primarily patients with connective tissue diseases, Ehlers-Danlos, and the like. And it's a very rewarding practice. The patients are generally much like chiropractic of 15 years ago. They are not understood well, and as a rule, they are grateful when someone takes the time just to listen.
And it's odd because you and I, through conversations, realize we have a special interest in those patients anyway. We didn't even know we had.
That's right.
So it's interesting, and thank you for volunteering the time to come here and also to be on our board of trustees. Katie, what's going on with you?
I am hopefully within the next 2-3 months defending my PhD, which is looking at the assessment of safety for chiropractic care in the pediatric population. And then getting lots of exciting research coming out of Parker University as well. Great studies going on.
We're glad to have you here. And before we end today, I want to remind everybody that we just started our own open access journal, the Journal of Contemporary Chiropractic, and we're accepting of course, reviewers who would like to help us out with that, but also we're accepting manuscripts. If anybody out there would like to submit, we'd really like to build this up to make it a premier research journal. Thank you both for joining us today.
Thank you.
Thanks, Bill. Great to be here.